A single clinical decision saved over $3,000 per admission. Now imagine what that looks like at scale. Most health systems introduce palliative care too late. They think palliative care is about the very end of life, but the delay is quietly costing millions. MedStar Health and UAB showed that starting palliative care earlier changes both outcomes and economics. They showed that investing in palliative care at the early stages is not only better for patients and families, it is one of the most financially intelligent decisions a healthcare system can make. Welcome to Healthenomics. I'm Dr. Ayoub Ashraf. I work in healthcare strategy and execution. In this series, we examine real success stories from leading health systems that how executives are solving complex challenges around cost, quality, access, and patient experience. I believe that keeping patients healthy, aligned with their goals, and out of the hospitals is not only possible, it is actually profitable. Let's talk about what actually works. Today's case focuses on how MedStar Health and University of Alabama at Birmingham re-engineered palliative care and what that decision quietly saved millions while improving patient and caregiver outcomes. UAB is a large academic health system anchored by a level 1 trauma center serving complex, high acuity patients across Alabama, while MedStar Health is a 10 hospitals learning health system across the Maryland and Washington, D.C., providing care to diverse and high need populations at scale. In many health systems, palliative care shows up very late, often when patients are already in crisis or after repeated hospitalization, ICU stays, and aggressive interventions that no longer match with patient goals. The result is predictable: higher costs, more suffering, burnout caregivers, and families left wondering why no one helped them sooner. What MedStar and UAB challenged was this assumption that palliative care equals hospice or that it signals giving up. They reframed it as an early clinical and operational strategy, one that starts upstream, not at the finish line. And when they did that, the results were striking. When palliative care was initiated within the first 3 days of admission, the system saved over $3,000 per patient, more precisely about $3,200 per case. If you apply that to just 1,000 admissions in a year, that is $3.2 million in avoided cost before you even factor in downstream savings. And the savings did not come from the denial of care, they came from better care. There were fewer ICU admissions, shorter length of stays, better system control, and more advanced care planning, and fewer emergency department revisits. In other words, the system stopped reacting late and started aligning care early. And this is an important point that all these patients were not at the end of life. Many were living with advanced heart failure, COPD, dementia, or cancer. They were high utilizers with frequent hospital visits, functional decline, and exhausted caregivers. Early palliative care gave these patients something most systems fail to provide, and that is clarity. Clarity around goals, clarity around treatment preferences, and clarity around what matters most to those patients. And when care aligned with those goals, utilization naturally changed. There was another outcome that leaders often underestimate, and that is caregiver impact. Families whose loved ones received early palliative support experienced significantly less trauma and complicated grief. In contrast, hospital deaths were associated with a 5 to 9 times higher risk of severe caregiver distress. So, this was not just a clinical intervention, it was actually a human intervention with financial consequences. Now, what made this work operationally was intention. Palliative care was not left to chance or individual physician judgment. Clear triggers were created based on utilization patterns, disease burden, and caregiver stress. They used remote palliative care models, which were based on telehealth, which is palliative care telehealth connecting to home. And the intention was to reach patients earlier, even outside hospital walls, providing home based and virtual consults. They called it as patch model. And importantly, care teams, including specialists, navigators, and care managers, were trained to recognize when palliative support should start. This shifted palliative care from a specialty silo to a system capability. So, what is the real takeaway for healthcare leaders? This case shows that early palliative care is not a cost center, it is a cost avoidance strategy. It reduces unnecessary hospital use, it stabilizes families, it improves satisfaction, and it quietly protects margins. This is not about less for patients, it is about doing the right thing sooner. For leaders facing rising utilization, readmissions, and caregiver burnout, the question is no longer whether you can afford early palliative care, but the real question is can you afford not to invest in it? This case was presented at the American College of Healthcare Executives Congress 2025 by leaders from MedStar Health and UAB, including Tom Reed, Jennifer Hicks, and Catherine Walker. I also want to clarify that I have no financial, professional, or advisory relationship with MedStar Health or UAB. Thank you so much for your time.